Thank you very much for joining us this evening or this afternoon or this morning, wherever you're watching this in the world and at whatever time of day. We're really pleased to have another one of our specialist webinars this evening. And as you can see from the title and as you can see from everything, this one's delivered by Chris. And Chris is one of our internal medicine specialist team. And we're going to be talking about localizing dyspnea today, a pattern-based approach to respiratory distress. So I think this is going to be really, really useful. It's certainly something that when I was in practice, just trying to localize things from what can be a very similar presentation in some circumstances and sort of getting that cognitive juices flowing to think, okay, well, where is this occurring before we get into the diagnostic tests is a really important area. And there's no one better to talk about this than Chris. So I'm really pleased he can talk about this tonight. Before I do, I'm just going to give a little bit of a discussion about why we're here and what our service is. So Chris, if you could just move the slide on, that's great. So I'm sure everyone knows, and if you've been to these webinars before, sorry, I'm going to do the promotion bit for VET.CT here. But whilst we've got everyone here, I think it's worthwhile doing. So VET.CT, as you know, we're a global team of over 200 specialists in the company. And we're essentially here to help. We're just here to help you guys out there in the veterinary world. We specialize in three major areas, really. So VET.CT is well known for its exceptional radiology. So radiograph interpretation, CT, MRI, and ultrasound. And that's the core service. But actually, what we're here to promote and talk about today, so all of these webinars are sort of introducing our team, and Chris is one of them, is the specialist advice service side of this. So we also have a really important education arm to VET.CT, where we work with the universities. We start to help residents and students in some cases, and the universities sort of build their services as well. So that's a growing and very interesting area for us. But essentially, with specialist written advice, we provide written specialist case advice within 12 to 24 hours. It's pretty simple. And what this advice enables you to do, it gives you sort of documented, validated advice from specialists to help treat cases in-house. You can rely on us for really fast turnaround times. We say 12 to 24 hours. There are some stats that we looked at that's much sooner often, and sometimes I think some of our stats are running at 2.5 hours as well. And the thing around what we provide, and we feel it's really core, and it is very, very difficult to deliver, but we offer unlimited follow-ups on our advice, because actually the advice that we give isn't just transactional. It's not just a one-off thing where we sort of jump in, we give you our opinion and we go. This is very much where we want to collaborate and work with individuals within different practice setups and primary practice setups and referral setups to inject the specialist expertise where we can, and also to support you in practice. So the unlimited follow-ups are a really important part of that conversation, where we will interact through our platform and our app, and I'll talk about that in a second. Essentially, what we provide to you is the detailed notes to add to the file and to share with the owners and to sort of share with your colleagues as well. And we find that clients are absolutely delighted to stay with the vet they know and trust in those early stages. Now, this is whether you're considering specialty referral outside the practice or whether you're actually working this case up, whether the client has funds or doesn't have funds. We're a very cost-efficient way of just injecting that specialist advice, but clients love it. The biggest thing we find with our clients, what's the most interesting, it doesn't necessarily always change what you do. It's not a profit generator for the practice necessarily, because it's just, we may change your plan. But actually, over half of our colleagues that we collaborate with give us feedback to say that it gives clear and detailed next steps and reduces that uncertainty. And that's really what we really pride ourselves on as well, that sort of reducing uncertainty. So the way you access us is two ways. You can go to VET.CT.com. So if you scan the QR code, I think that takes you through. But we also have an app on the phone as well, or a tablet. So you can go to the Play Store or the App Store or whatever store you have. And you can see we have this sort of interactive app here. So you can generate cases very, very quickly. And I only found out the other day, if you've got a phone, for example, you can use a dictation, the microphone, to actually dictate into the app to generate your case on the go. The beautiful thing about the app or a tablet app as well is that a lot of what we do and I'm sure Chris will talk about this today, is that we can absorb multimedia sort of files. So videos, photos, it all helps us. And I'm sure in respiratory dyspnea, it's really, really helpful. So if you've got something in your hand, or if you've got a practice tablet or something like that, to get a video, you can upload it straight away, straight into the app. You can do it in the desktop as well. But it's really, really, really useful. And it was something I just realized the other day. So the way that you pay for us as well is really important, because a lot of people say, well, how do we pay? So you don't need a subscription. We offer subscriptions on an individual basis, on a practice basis, and we have hundreds of practices using us on a subscription basis, which is where you get unlimited advice. You don't have to think about the payment, or you can get case-by-case advice just on a pay-as-you-go, which is just invoiced afterwards. So if you want to know more, please get in contact around that. So Chris, if you can just go to the next one. If you did want a demonstration webinar at all about our services, how to use the platform, anything like that, then email me directly, richard.artingstall@vetct.com. Have a look at the website. There's some videos on there as well. But have a little explore, and we'd love to start working with you if you're not working with us already. Next slide, please, Chris. So just a bit of housekeeping for today. All of these talks are going to be recorded. So everybody that's registered will get an automatic link through, and you can watch this pretty quickly. It normally comes through in a few minutes after the webinar. Any questions, there's a Q&A box at the bottom. If you can pop the questions in the Q&A, and then we can go to that at the end. Everybody's going to be on mute as well for this talk. So just to let people know. Okay, right. I think that's almost me done. So yeah, really pleased to introduce Dr. Chris Byers. He's one of our internal medicine team, ABVS recognized specialist, and recognized veterinary specialist in small animal internal emergency critical care as well. So very, very qualified to talk about this subject, which is localizing dyspnea and a pattern-based approach to respiratory distress. So I'm really interested in listening to this talk. And I'll stop talking, and thank you, Chris. Over to you. Thank you.
Thanks, Richard. Hi, everybody. It is the middle of the afternoon for me, but good morning, good afternoon, good evening from wherever you are joining. In the interest of being transparent, I do have some disclosures that I will share, but nothing here impacts or influences my ability to talk about one of my least favorite topics. And that's because as a criticalist after 2+ decades, I still do not like respiratory distress. I always question the sanity of colleagues who say they like respiratory distress, because my sphincters still tighten when a patient in respiratory distress comes through the door. So my goal with this presentation is simply to introduce you to, or perhaps reiterate the concept of evaluating a patient's breathing pattern to help you localize where within the respiratory tree a patient's problem is. And we're going to use real case examples that I've accumulated over the years to help highlight this approach. It's very similar to neurolocalization. For example, we're all used to saying, oh, that's a C1, C5, or that's a T3, L3 lesion. And then we can come up with reasonable, logical differential diagnoses depending on where within the spinal cord we think our patient's problem is. We take that same approach with the respiratory tree. Is it upper respiratory? Is it lower airway? Is it pleural space, etc.? So the first job for each of us when we are presented a patient in respiratory distress is actually identifying that. And that's not meant to be a trivial point. It is often quite challenging. And I use the cat that you see on the right side of your screen as a classic example. Think about cats when they're presented to you. They're in their carrier. They are usually at the back of the carrier, and often they've buried themselves beneath a towel. And so sometimes the only thing you and I see is their adorable little face and maybe just the tip of their nose. And so what the kitty that you see here on the right side of your screen is showing you is nares flaring. And if you see a cat with nares flaring and nothing else, that should alert you that that patient is struggling. That patient is experiencing respiratory distress and you need to act accordingly. When a patient is presented in respiratory distress, that is not the time that we do a complete physical exam. Yes, you heard that correct. I am telling you not to do a complete physical exam when a patient is presented in respiratory distress. Rather, your focus needs to be on performing a primary survey. That is evaluating airway, breathing, circulation, neurological dysfunction, anything environmentally associated with that patient that you need to immediately address. Once you've implemented whatever appropriate stabilizing measures you feel are appropriate, then you'll come back and do a secondary survey, which is essentially completing your physical exam. What I want you to start doing as part of your primary survey is initially breathing with your patient before you lay hands on them. I don't want you to touch them initially. I just want you to watch them breathe and try to breathe with them. I want you to emulate their breathing pattern without making yourself pass out or faint. We don't want that. You're of no use to your patient if you pass out. But I want you to engage that sense. I want you to hear, I want you to smell, I want you to see, but I also want you to embrace the tactility of breathing with your patient, recognizing at any point you may need to capture that patient's airway. You may need to crash induce to intubate or to perform a tracheostomy. And the reason that we evaluate their breathing pattern before laying hands on them is because as soon as you and I touch a patient in respiratory distress, the stress that we induce just by being the big, bad, scary people who may be wearing a white coat is that respiratory pattern will change. And when it changes, that can now muddy the proverbial waters. It can make it much more challenging for us as veterinary healthcare team members to figure out what's going on with our patient. In general, when we're talking about patients in respiratory distress, we're trying to decide, is the problem inside or outside the chest? So extrathoracic, which is characterized by increased inspiratory effort, or is it intrathoracic, where patients will classically demonstrate increased expiratory effort? So a major takeaway here is when you're writing up your medical records and you write increased respiratory effort or increased RE, that's actually incomplete. We want to be more helpful than that. We want to write something like increased inspiratory effort or increased expiratory effort. That additional adjective, that additional descriptor really does help. Some people like to think of respiratory disorders as being obstructive versus restrictive. So think of obstructive as the classic upper airway problem where you have to really breathe deeply and with a lot of effort just to get air into the lungs, and contrast that to patients with, let's say, pleural effusion, where the lungs can't fully expand. So to exchange the same amount of oxygen and carbon dioxide, because those lungs can't fully inflate or expand, the patient has to breathe much faster, but the tidal volumes are markedly reduced. They're shallow breaths. So as we go through several videos during our time together, I want you to ask yourself specific questions as you are watching the videos, as you are listening, as you are breathing with the patient. And these are the questions that I classically ask myself every single time I am observing a patient breathing. If an owner says, my cat is not breathing properly, I'm concerned about my dog's breathing, it's hard to understand what they are describing, even when they are being as verbally descriptive as possible. Get them to take a video. The video is immeasurably helpful to help us answer these questions, because ultimately we are trying to decide where in the respiratory tree a patient's problem is. And these are the major locales. So let's jump into our first case. This is a 11-year-old female spayed mixed breed dog who was presented to my colleague, who is a surgeon. I was in my office doing paperwork, because that's what internists do. We do a lot of paperwork. We look at a lot of records. And I get paged stat to the orthopedics room, because this patient came in for concern for a ruptured cranial cruciate ligament. But I'm not getting page stat for a ruptured ligamentous injury. I'm getting page stat for this. So if you breathed with that patient, I hope you recognize that you are putting more effort into breathing in. Certainly, we're also making noise, and that patient was stressed. This was a patient with known laryngeal paralysis due to geriatric onset laryngeal paralysis and polyneuropathy, or GOLLOP, who stressed out during her examination. And the surgeon said, I don't deal with this, get the criticalist. And so we took care of her. She just needed a little bit of sedation. And the focus turned to, well, let's deal with the GOLLOP before the ruptured cruciate ligament. The takeaway here is this is an obstructive breathing pattern where the patients will put much more effort into breathing in compared to breathing out. And we want to listen for specific sounds. The sound you heard with this dog is called stridor, which references the laryngeal apparatus. Sometimes we'll hear stertor or congestion, which references the nasopharyngeal region. Oftentimes, these patients are quite anxious, so we need to be prepared to relieve an obstruction if that's possible. If it's a foreign body, we want to remove it. If the airway is collapsed, we'll need to capture the airway and provide emergency intubation or possibly even an emergency tracheostomy. Here's another video. So nobody wants to hear that noise. That is the classic sound of a sucking chest wound. And there is no noise that will get an emergency doctor or a criticalist to jump to their feet faster than hearing that kind of noise. But that is a pretty interesting patient who was attacked by a larger canine member of the house, in that we have two chest wall injuries. We have the sucking chest wound, but to the right of that sucking chest wound, we also had a flail segment, which is essentially two or more consecutive ribs broken at two or more places, resulting in a free-floating segment of rib that moves paradoxically with inspiration versus expiration. And that's because of the differences in intrathoracic pressure. These patients are exquisitely painful. If anybody has ever bruised a rib or fractured a rib, you know the discomfort that these patients have. And so in addition to an obviously palpable thoracic wall deficit and a flail segment moving independently of respiration, these patients have a very shallow breathing pattern. It's a restrictive breathing pattern because it hurts. They're trying to limit the excursions of the thoracic cage as much as possible. So we need to be prepared to not only ensure that they are able to oxygenate and ventilate adequately, but we need to ensure that we are providing exquisite multimodal analgesia using our choice of a validated objective pain scoring system to serially assess their response. Interestingly, many of these patients with flail chests, for example, do not need surgical stabilization. We only pursue surgery for flail chest when they aren't responding to typical medical interventions. And of course, there are many different ways to stabilize that flail segment. When we have puncture wounds, we need to thoroughly explore them once the patient is more stable and either allow things to close by second intention or do a delayed primary closure. Let's move on to our next patient. So this is a 2.5-year-old male neutered domestic shorthair who was presented in respiratory distress to the emergency room. As you can see here, we've taken the top off the carrier, we've removed his blanket, but we're taking a brief moment to breathe with him. And I hope you all noticed the nares flaring when his nose appeared in the video. But if you breathed with him, I hope you realize that not only were you breathing loudly, or breathing rapidly, excuse me, you weren't really making any noises, and the breaths that you were taking were shallow, rapid, shallow breathing. So a restrictive breathing pattern. But he has no palpable or visible chest wall injuries. And so when we're thinking about restrictive breathing patterns, fast, shallow breathing that's not involving the chest wall, this is where we should think about the pleural space, whether that is fluid accumulation or air accumulation or combination of both. The fact is the lungs are prevented from properly expanding, so oxygenation and ventilation is compromised, and they are breathing more rapidly to try and achieve the same oxygenation and ventilation goals that they would as if the lungs were able to properly expand and there was nothing in the pleural space. My major takeaway from discussing pleural space, aside from obviously recognizing that the pattern is restrictive in nature, so short, shallow tachypnea, is you need to perform a thoracocentesis. If you're going to refer this away to out of hours for continued care, if you're going to refer it to a specialist for further evaluation, that's fine. But to maximize the likelihood of that patient arriving alive at the out of hours facility or at the referral facility, to pursue further diagnostic investigation, if that's not something you're comfortable doing, please take the time to perform the thoracocentesis. Unfortunately, I have seen too many patients arrive dead on arrival because they died in transit because nobody did a thoracocentesis prior to referral to emergency room or to the tertiary referral hospital. Okay, case number 5. Nobody gets to laugh at this patient. This boy is one of my favorite patients of all time. He is a 4-year-old male neutered Sphinx who is my favorite little alien. Turn your volumes up because there is noise to hear. I mean, he's adorable. This was one of the patients that I saw when I was on the medicine floor who was referred for coughing. Obviously, I wasn't able to capture him coughing, but if you breathed with him, what I hope you were able to sense and engage was that you're putting more effort into breathing out. And when you were breathing out, you found yourself making a noise, a grunt. So he was having no trouble breathing in, but when he breathed out, he sounded like, "Ugh." And this is a classic example of a cat having an asthma attack. This is a small airway disorder, and small airway disorders in dogs and cats are characterized by prolonged expiration. There's increased expiratory effort. These patients often have wheezing that is maybe only heard on auscultation. Cats and dogs will cough. Remember, cats coughing means airway disease. Cats coughing does not mean heart disease. Coughing cats do not have heart disease. And if you or any of your loved ones have asthma, you know that they'll often describe really needing to put in a lot of effort to get air out. And that's because air commonly gets trapped in the alveoli because those small airways are hypersensitive and filled with more mucus. So it's harder to get the air out of the alveoli to the outside world, to breathe it out. So we need to provide them supplemental oxygen. We often need to provide them sedation, for example, something as simple as butorphanol. We often will use bronchodilators, whether that is an albuterol or salbutamol inhaler or a terbutaline injection. And because we're concerned about asthma, this was confirmed asthma based on ruling out other differentials, an anti-inflammatory treatment with a corticosteroid is very reasonable, but perhaps underappreciated in the management of these patients is the fact that they need minimal handling in a quiet environment. We really need to take a hands-off approach initially until they are better stabilized. Because if we manipulate them, restrain them too much during this distress, we could push them over the proverbial edge and unfortunately cause disastrous outcomes, including death. The next case is a 9-year-old female spayed mixed breed dog who was presented to her primary care doctor earlier in the morning on the day of presentation for a COHAT, a comprehensive oral health assessment and treatment. And everything went beautifully during anesthesia. And about 3 minutes after they extubated her in recovery, she regurgitated. And so her primary care team brilliantly reintubated her immediately, performed oral lavage to get all the regurgitant out of her cavity, and actually transported her to our emergency room for continued care because they were concerned about aspiration. There's no sound of importance here. I just want you to breathe with her. She's clearly stable in this oxygen cage. And we found her to be a very interesting example, but a classic example. Her chest radiographs that I didn't include here just for time were classic for aspiration pneumonitis / pneumonia, in that the right middle lung lobe was had soft tissue opacity consistent with that etiology. And her primary care doctor brilliantly intervened, and I give all the credit to that team for the fact that this little kiddo was able to go home less than 36 hours later, doing well with appropriate therapy. But when you breathed with this patient in terms of pattern, what I hope you appreciated was there wasn't a pattern. At some times when you're breathing, you were like, yeah, these breaths seem a little shallow. Oh, is this restrictive? Is this a pleural space disease? But at other times, you found yourself taking reasonable tidal volume breaths. So there really was no pathognomonic pattern to the breathing. Sometimes we put a little bit of more effort into breathing in. Sometimes it seemed like we were putting more effort into breathing out. When we auscultate, these are the patients that we can hear adventitious lung sounds, abnormal bronchovesicular sounds. This is the category pulmonary parenchymal disease, where we worry about things like congestive heart failure or non-cardiogenic pulmonary edema. So we may also hear concurrent dysrhythmias or murmurs. And it's beyond the scope of this time together to talk about the management of all of these potential pulmonary parenchymal disorders. The takeaway here is there is no pathognomonic pattern for patients with true lung disorders like there is with lower airway disorders or upper airway disorders or pleural space disease. This is an 8-year-old male-neutered Yorkshire Terrier who was one of my patients with a protein-losing enteropathy. Very well controlled, and about 3.5 months before this presentation, I had seen him, gave him a beautiful, stable bill of health. Biochemical profile was beautiful. His owners were happy. His owners worked intermittently in Japan, both of them. And so during their long stretches, like 2.5 to 3 months at a time, this kiddo was under the care of a family member or a pet sitter, because they weren't traveling back and forth from the United States and Japan with this kiddo. Sadly, frustratingly, this is him being presented to the emergency room basically upon the owner's arrival home. This is how they found him when they walked through the door, and they immediately presented him to us.
Partial.
And so no real noises to hear of him, but you may have heard 2 other criticalists in the background describing his breathing pattern to each other, because we were all there while they were setting up the oxygen cage for him. But from a pattern perspective, he's certainly tachypnic. I hope you can appreciate that when you look at his elbows, they are bilaterally abducted. He has those elbows moved so far away from his chest to allow maximal expansion of his thoracic cage. Sometimes it looks like he's putting a a lot of effort into breathing in, sometimes breathing out, but really no specific pattern. And so we're starting to think, is this pulmonary parenchymal disease? But unfortunately, this is something far more severe. This is pulmonary thromboembolism. This is a challenging diagnosis to make. But if you look at those major differentials on the right side of your screen, that is a typical day on the medicine floor. We see patients with Cushing's, protein-losing nephropathies, protein-losing enteropathies, immune-mediated hemolytic anemia, multiple times a day. The risk of our patients developing pulmonary thromboembolism is quite high, but diagnosing it accurately is quite challenging because it requires advanced imaging, CT angiography, which a lot of places don't have CT capability. And for those that do have CT capability, the concept, just the mere thought of anesthetizing a patient like this makes sphincters really tighten and pucker up. So nobody really likes to do it. And why did this patient develop a pulmonary thromboembolism? That was diagnosed on autopsy, so that was the outcome. It's because for the previous 3 months, so shortly after I saw him 3.5 months earlier, when the owner was in Japan, the pet sitter didn't give any medications. And so his protein-losing enteropathy came out of control, and that predisposed him to developing a PTE, which is exactly what you just saw. And the last case that I have to share with you is a 12.5-year-old male-neutered Australian Shepherd. There is no noises to hear, but you can breathe with him. Okay. So this is an example of a patient who has mild tachypnea. He doesn't look profoundly stressed. He's looking at the videographer like, why are you videoing me? He's quite comfortable laying there. And that's because this is an example of what we call a lookalike. He has no problems with oxygenation or ventilation. This patient is not experiencing hypoxia. Rather, this patient was bleeding from an inoperable hepatic tumor causing a hemoabdomen. And so there are disorders that have nothing to do with the airway that can make it look like our patient is experiencing respiratory distress. And we may frequently get calls from owners about patients with these conditions: hypotension, pain, pyrexia, adverse effects of drugs, for example. Now, this patient, in full disclosure, was my heart dog, Avery, and he did indeed have an inoperable liver tumor. And so that was his last day with us, and he lives on in that video to help share experiences with lookalikes. So that is our time chatting about how we can use respiratory patterns to help us localize where in the respiratory tree a patient's problem is. Because whether we like it or not, respiratory distress is going to happen. It's probably going to happen in the middle of the craziest work day that we have and really mess with our schedules, but it's going to happen. So we need to be prepared to perform that primary survey which now will include taking a moment before we lay hands on the patient to breathe with that patient to help identify where in the respiratory tree the problem is. Without hesitation, we will capture a patient's airway if we think that is necessary. So I appreciate you spending part of your morning, afternoon, evening with me to cover this topic. I'm happy to answer questions. We have more webinars coming up, so I encourage you to scan the QR code to register for more. I'm going to turn it back over to Richard to facilitate any questions that any of you may have. But thank you very much.
Yeah, great. Thank you, Chris. So there's a Q&A box at the bottom. If anybody's got anything that they want to ask around this lecture, that'd be great to pop in there. For me, Chris, it's such a simple thing. You often come up with such simple things, but just actually breathing with the patient. And I think I've always done that subconsciously and not quite realize you're doing it, but you're panicking at the same time. You're thinking through so many other things. But I think just almost that mindfulness moment of looking at a dyspneic patient and actually breathing with them probably gets you 50% of the way there, doesn't it?
Absolutely.
It's amazing.
It,
Yeah,
it,
it's
it
such a simple thing.
really is. It's such a simple concept
Yeah.
that so many of us forget about. And so when we're dealing with such a common problem, trying to come up with just simple things to help us stay focused really works for my brain that needs things to be as simplified as possible. So let's just look at breathing patterns.
Yeah. Yeah. Simple as. Yeah, it's really good. So I've got a couple of questions actually. For me, when I was in practice, I was comfortable with upper airway, lower airway. I was comfortable with inspiratory sort of signs as well. But what I always struggled with was just the decision-making process without diagnostics necessarily around pleural space, small airway disease, cardiogenic edema, maybe something like that. Have you got any tips for once you've localized it down a little bit, instead of just diving for an X-ray or diving for anything else, have you got any tips around you started to localize it maybe in a lower airway setting? And are there any simple sort of tricks of the trade that you can recommend around that?
So I would say that if one has a trigger to reach for radiography, we need to abandon that trigger.
Mm.
The fact is, in emergency medicine, we're moving very much away from at least initially embracing radiography because it requires restraint. And depending on one's jurisdiction and local and federal regulations, that restraint may be lethal in that the stress associated with it could put a patient over the edge and actually kill them. So in the emergency room now, we don't talk about, I need to get those x-rays as quickly as possible. Really don't care about the x-rays during the stabilization period. With the availability of abdominal sonography in most practices, including First Opinion, we embrace thoracic point of care ultrasonography, or POCUS. That can be performed in any recumbency. It can be performed with minimal restraint. We don't need to shave. We can just use some lube. Some people like to use a combination of lube and alcohol, but the point is it's much less invasive than thoracic imaging. And so if you've evaluated a patient's breathing pattern and you say, for me, all my senses tell me that this is pleural space disease, and then you have an ultrasound bedside, you can use that in a relatively safe manner to quickly confirm what your senses, what your physical exam primary survey was telling you. If it's not pleural space disease, for example, and you're thinking that it is lower airway disease, then We're looking at things like B lines. We're looking for those lung rockets, as they're sometimes called. And if lung rockets are there, it tells us that we have quote unquote wet lung. And so not lower airway disease if we see wet lung or B lines. And so then we look at what's the pattern of distribution in each hemithorax for those B lines to help us prioritize. Is this more consistent with pneumonia, cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, etc. So there's a lot of utility in something as non-invasive as POCUS of the thoracic cavity while delaying thoracic radiography for patient safety.
Yeah, I completely agree. Someone told me that once, and I started, and they said also, if we've got dogs for routine chest x-rays or something, then just try a POCUS pretty quickly, just to get familiar with what the lung looks like, because it's not often so familiar with us. I think we're so familiar with x-rays, and actually just getting that used to that different familiarity in the machine that you've got is really
Yeah, I encourage team members who want to improve their comfort performing thoracic POCUS or abdominal POCUS to have in-hospital training sessions where, maybe after hours as a team building event, you identify some employee-owned healthy pets, and everybody takes a turn doing POCUS of the abdomen and POCUS of the thorax, on an amenable patient that is normal to learn normals, because that's always the first challenge, right? What is normal versus what is abnormal? Well, image as many patients as you can.
Yeah, absolutely. Okay. I just wanted to say something about the images, because I mean the images are so powerful and the videos are so powerful, and we rely often on serial videos to be taken just so we can evaluate them, as your team, Chris, know. But I think just looking at those videos there reminded me to just remind everybody that if you do have dyspneic patients in, then taking a video and then taking serial videos for your own use and your colleagues' use is very, very useful to save those descriptive difficulties of how are you characterizing that dyspnea. But certainly, sending them to us as well is vital for anything like that. Okay, well, I think we've reached the end of the webinar. So we've got one more webinar in 2 weeks' time in oncology, and it's going to be a really interesting one, actually. I'm really looking forward to it. It's how to evaluate quality of life of dogs with cancer. So I think it's just going to be really one of those interesting webinars, which is going to make us think, I think, and I'm looking forward to that one as well. And then we're going to probably take a pause, and I think we're back with webinars again in September. So if you do want to have a look at the previous webinars, they're all on the website, and you can look back at them for free. Do have a look. We've had some great ones from all of our specialist team, and you'll get to put names to faces as well. Chris, can I thank you so much for your talk today? I thought it was brilliant. As always, really practical, really, really focused. And thank you everyone for joining tonight as well. Oh, hold on. I think we've got a question. Yeah, we do have a question. Sorry, Chris.
Sure.
Actually, this is a good one. How would you handle a case where the animal's aggressive and requires sedation for any investigation, I presume with dyspnea?
That's an awesome question, to be honest with you. So for patients who are aggressive and require sedation, being as safe as possible, we have to sedate them. So using the safest modality, you do you get them sedated as rapidly as possible, and you capture the airway. That's going to be your top goal. By getting that patient sedated and intubated, I find that I'm able to say, okay, my staff is now safe because the patient is out, and that airway is captured, therefore it is patent, and I can control oxygenation and ventilation if I need to. So That stress level has also gone down. So I'm happier because I know my patient can breathe because their area has been captured, and I know my staff is safer because we were able to sedate them. In terms of what I sedate them with, because that's probably the next logical question, I will typically try to get an IM injection of alfaxolone on board with a little bit of a benzodiazepine.
And that was the second question.
Oh, okay, good.
Brilliant. Just interestingly, just on capturing the airway, is there anything that in particular would trigger you to then go into trying to capture the airway in a dyspneic case? I know that's a big topic, I know.
That's my favorite question. It's the answer that I'm going to give is not meant to be flippant, but it is exactly what I teach students and house officers on the floor, and I think it's worth sharing with any colleague. The first indication for capturing a patient's airway, for performing intubation, is thinking that you need to capture the patient's airway.
Yeah,
so
okay.
if the mere thought goes through your mind that I need to do this, you should do this. Now, I understand that that can be an anxiety-ridden decision because the thought of sedating a patient in respiratory distress freaks a lot of people out, but I promise you, if you have control of that patient's airway, you can control oxygen and ventilation better. And if your patient's oxygenation and ventilation is controlled better, so too is yours, because you can have a little woo-saw moment, take a deep breath, calm yourself down, engage some of that parasympathetic nervous system that you need to engage, and then continue working for that patient to figure out what caused the respiratory distress and start additional interventions to further help them breathe.
Great advice, thank you. Okay, so I think that's it. But yeah, thank you, Chris. Thank you as always, and thank you for joining us tonight, guys. And then we will hopefully see you soon at the next one. Okay, wonderful.